Thank you, Dr. Govind, for the kind words. So, I'll be talking about cerebral edema and the battle with the bulge today. So, why is it important? Because cerebral edema is frequently encountered in clinical practice in critically ill patients with acute brain injury from diverse origins. And the consequences of cerebral edema can be lethal and can include compromised global or regional cerebral blood flow, and also intracranial compartment shifts and compression of vital organs. So, how do we define it? We define it as an accumulation of fluid within the intracellular, extracellular or intracellular CNS elements over and above 80% which normally exists in the brain. Etiology can be variable, so I'm not only going to talk about TBI here, I'm going to talk about a varied etiology here. It's going to be TBI, subarachnoid hemorrhage, ischemic strokes, intracranial hemorrhages, primary and metastatic neoplasms, inflammatory diseases like meningitis, ventriculitis, abscesses and encephalitis, and obviously toxic metabolic derangements like hepatic encephalopathy. So as I told you, it can be varied, it can be an infarct, it can be SH, ICH, it can be a SOL, it can be traumatic brain injury. All these things would lead to edema. So traditionally it's been classified into three major subtypes: cytotoxic, vasogenic and interstitial. Why are the subtypes important? They are important because the etiology is different, and also the treatment is slightly different. Although highly simplistic, it is valuable as a simple therapeutic guide for treatment of cerebral edema, and most brain insults involve a combination of these fundamental subtypes, although one can predominate over the other. So cytotoxic edema is a subtype in the initial accompaniment of any brain injury. Cytotoxic edema results from swelling of cellular elements like the glial cells and the neurons, and because of the substrate energy failure, and affect both the white and the grey matter. So on a T2 weighted or a DWI imaging, there will be decreased signal intensity, and on the apparent diffusion coefficient on an MRI, there will be restriction diffusion. So this kind of edema is non-responsive to glucocorticoid therapy and is minimally or transiently responsive to osmolar therapy. Whereas vasogenic edema, the etiology is different, defined as excess fluid within the interstitial space, and common causes would include your malignant tumors, abscesses, surgical manipulation, meningitis, encephalitis, contusions. And they tend to be more responsive to the glucocorticoids and osmolar therapy. So that is why post-op you would give steroids in this subset of patients. And there would be an increased signal on the T2 and diffusion weighted imaging, and apparent diffusion coefficient in the ADC on the MRI. Interstitial edema would result from impaired absorption of CSF, manifest as acute or chronic hydrocephalus. Edema substance is not responsive to steroids. Its response to osmotherapy is also unproven and debatable. So we all know the Monro-Kelly doctrine, which states that the skull is inelastic, intracranial contents are non-compressible, and the overall volume of the cranial vault must remain constant, so that an increase in volume has to be offset by an increase in ICP. So irrespective of the elevation of the ICP, the consequences of focal or global cerebral edema are inconsistent with the doctrine. The cerebral ischemia forms from compromised regional and global blood flow, and intracranial compartment shifts due to ICP gradient results in herniations. So if you look at the herniations, there can be a subcalcine herniation, there can be a uncal herniation, there can be a cerebellar herniation, and there can be a transcalvarial herniation. So I won't go into the details of these herniations, but serial and close bedside monitoring with a focus on level of consciousness and new or worsening focal neurological deficits is imperative. And in a given clinical setting, you have to look at the alteration in the level of consciousness, that's your GCS score, any bradycardias, any blood pressure surges, abnormal breathing patterns, ocular movements, pupillary size, and extensive plantar reflex on the side of the lesion should all raise a strong suspicion of cerebral edema. So where does ICP monitoring stand in this whole gamut? It's helpful in patients whom neurological status is difficult to ascertain, especially if they are under muscle paralysis. The Brain Trauma Foundation guidelines recommend ICP monitoring in GCS less than 9 and an abnormal CT scan. In patients with GCS less than 9, a normal CT scan, the presence of 2 or more, that's age more than 40 and blood pressure less than 90 is important. No such guidelines exist for ICP monitoring in other brain injury paradigms like ischemic stroke, ICH or neoplasms. Investigation wise, CT or MRI imaging is one of the most important investigation, particularly useful in confirming your intracranial compartment midline shifts, herniation syndromes, ischemic brain injury, and exacerbation of cerebral edema like the sulcal effacement and obliteration of the basal cisterns. CT scans provide an excellent tool for in vivo determination of abnormalities in the brain water content. The area of edema appears on low intensity on the CT, and this is due to dilution of the constituents of the white matter. Cerebral edema in acute vascular lesions can be seen in both cortex and the underlying white matter, and the cerebral edema in epidural and intracerebral hematoma is limited to white matter only. So talking about management can be broken up into general management, medical management and the surgical management. General measures would focus on limiting the edema. Overriding goals for the applications would include optimizing cerebral perfusion, oxygenation and venous drainage, minimize cerebral oxygen demand, avoid intervention that may perturb the ionic or the osmotic gradient between the brain and the vascular compartments. So obviously optimize your head position, 30 to 60 degree, neck position should be midline, PO2 of around 100, normocarbia of around 35, normothermia, normoglycemia, maintain CPP of 60 or above slightly, adequate nutrition and seizure prophylaxis. So finding the optimal neutral position to promote cerebral venous drainage, elevation to 15 to 30 degrees, head position elevation may be significant concern, especially in the ischemic stroke patients, and also while you are fixing your endotracheal tubes and your central lines, so be aware of your internal jugular veins. Ventilation and oxygenation as dictated by the principles of cerebral physiology, hypoxia and hypercarbia are potent cerebral vasodilators and should be avoided in patients with cerebral edema. PaCO2 should be maintained at level that supports adequate regional cerebral blood flow to the injured brain, and a value of around 35 is generally accepted target. Avoidance of hypoxemia is something which should be maintained. Any patient with GCS less than 8 should be intubated and the airway secured. Delivery of PEEF greater than 10 is avoided in patients with TBI. Careful monitoring of clinical neurological status, ICP, CPP in mechanically ventilated patients with cerebral edema, with or without elevation in ICP. And while you're doing your suctioning and while the patient's coughing, you can use maneuvers like lidocaine while suctioning and giving some sedation before you do a suctioning, because you don't want the ICP to go up, especially in where the ICP is already raised. So maintenance of intravascular volume is something which is also important. Avoid systemic dehydration and the use of hypotonic fluids. Euvolemia or mild hypervolemia should be targeted, and rigorous attention to electrolytes and fluid balance should be maintained. Maximum blood pressure tolerated in different clinical situations is variable. The recommendation goal of CPP of 60 should be adhered to, and judicious use of antihypertensives like labetalol and enalapril nicardipine is recommended, and vasodilators like nitroglycerin, nitroprusside, etc. avoided in traumatic brain injuries and in cerebral edema. Fever is detrimental, normothermia is recommended, paracetamol 325 to 650, 4 to 6 hours, most commonly used agent. Some efficacy of other surface cooling endovascular cooling devices have been demonstrated. Glycemic control, obviously hyperglycemia can also exacerbate brain injury, and there is evidence that in ischemic stroke and SAH is a strong correlation with hyperglycemia and adverse clinical outcomes. Nutritional support is important. Prompt institution and maintenance of nutritional support is imperative in all patients with acute brain injury. Unless contraindicated, enteral nutrition is your preferred route, and special attention should be given to osmotic content and formulations to avoid free water intake that may result in hyposmolar state and worsen cerebral edema. Seizure prophylaxis, again, use of prophylactic anticonvulsants is controversial. The TBI, the Brain Trauma Foundation guidelines say it is imperative to use them for a week. Rest and all other injuries like the SAH, ICH, stroke, neoplasms, currently it's tailored to individual patient use and no guidelines exist as to how long they have to be given. Medical management would include hyperventilation, osmotherapy, loop diuretics, corticosteroids, analgesia, sedation, paralysis, and pharmacological coma and hypothermia. Controlled hypoventilation is only a rescue or resuscitative measure for a short duration until more definitive therapy is instituted. Common clinical practice would be lower and maintain PaCO2 by 10 to a target level of approximately 30 to 35 for 4 to 6 hours. Decrease in PaCO2 by 10 produces a proportionate decrease in the regional cerebral flow and resulting in rapid and prompt ICP reduction. But mind you, the vasoconstriction effect of respiratory alkalosis on cerebral arterial lasts only from 10 to 20 hours, beyond which there would be a dilatation and a rebound cerebral edema. So prolonged hyperventilation would result in worse outcomes, and caution should be extended in reversing hyperventilation judiciously over 6 to 24 hours to avoid cerebral hyperemia and rebound elevation of ICP. Osmotherapy, the goal of osmotherapy for cerebral edema is associated with brain injury is to maintain a euvolemic or slightly hypervolemic state. Serum osmolality of around 300 to 320 is targeted, but serum osmolality values of more than 320 can be used with caution without apparent untoward side effects. So characteristics of an ideal agent would be produces a favorable gradient, is inert, non-toxic, excluded from intact blood-brain barrier, and has minimal side effects. So refractory index of 1 is what is needed. Compounds with a refractory index of 1 are considered to be better osmotic agents, and because they are completely excluded and conversely less likely to exhibit rebound cerebral edema. So as we see, sodium chloride has a refractory index of 1, mannitol of 0.1. Glycerol is still used in certain centers, urea is not used. So mannitol has been the bread and butter drug for conventional osmotic therapy in a dose of 0.5 to 1.5 grams per kg. The effect is seen within 20 to 40 minutes. Repeated dosage 6 hourly can be given, but higher values can result in renal tubular damage. Hypertonic saline is something which is now being used in more and more centers. You get it in all percentages from 2, 3, 7.5. In India, typically we get hypertonic saline as a 3% solution. Hypertonic solution as a variable rate, you can run it at a variable rate at 1 to 2 ml per kg per hour. Plus you can substitute and top off with boluses of 250 ml of hypertonic saline if more aggressive and rapid resuscitation is warranted. The goal is to achieve a concentration of sodium of around 155 and osmolality of around 300 to 320. Normovolemic fluid status is maintained. A serum sodium is maintained for around 48 to 72 hours until the patient demonstrates clinical improvement. So there is a lack of response despite the sodium being achieved. During withdrawal therapy, special caution is emphasized owing to possible rebound hyponatremia. Serum sodiums to be done at least 3 to 4 times a day. And you need to look at your x-rays, and you need to do a baseline echo, because obviously pulmonary edema and congestive heart failure is something which you need to take into account before you institute hypertonic saline therapy. So which one's better is probably up to you, because the Brain Trauma Foundation does not give any guidelines as to one is better over the other. Although more and more papers are coming in favor of hypertonic salines, lots of units are changing from mannitol to hypertonic saline, but still it is up to your clinical practice and your intensive care unit what you need to practice. We are in a process of using both at this time, but we are now tipping more towards hypertonic saline rather than mannitol. There is no class 1 evidence showing superiority of one agent over the other. So the pros and cons of both. Demyelination, not as commonly seen as documented. Acute renal failure in mannitol, volume overload, electrolyte imbalance, thrombophlebitis could be there in both of them. Rebound edema can happen in both of them. Electrolyte disturbances will happen in both of them. And so which one do you prefer? Well, studies are more skewed towards use of hypertonic saline now, but well, the choice is still yours because there are no guidelines for that. Diuretics, furosemide is something which will be very commonly used, but not as a lone therapy. It will be used as an adjuvant therapy, and 0.7 milligram per kg is something which will be used. Attention needs to be paid to the hydration status. Acetylizonamide would only be used in case of raised ICP and CSF leak, or in a pseudotumor cerebri. Corticosteroids, the main indications will be vasogenic edema. Steroids decrease the tight junction permeability in the blood-brain barrier. Glucosteroids, especially dexamethasone, are preferred agents due to its low mineralocorticoid activity. And in TBI and stroke, steroids have failed to show any substantial benefits. Analgesia and sedation is something which is important. Pain and agitation can increase your ICP. Judicious bolus of narcotics like fentanyl or maybe even morphine can be used. Special care must be taken for airway protection. Neuromuscular blockage can be useful adjuvant in control of refractory ICP, although majority of the times sedation alone would suffice, but once in a while you do have to use your muscle relaxants, but then mind you, it is difficult to do your neuro-obs once your patient's paralyzed. Barbiturates, numerous studies have shown that barbiturates are neuroprotective and lower ICPs, but the use of barbiturates in clinical practice have not really translated into good outcomes. So evidence is limited for use of barbiturates in the setting of several pathologies like SOLs, although it is still used in status epilepticus. Propofol is emerging as an alternative, efficacious in controlling ICP in TBI patients. It has an anti-seizure property as well and decreases your cerebral metabolic rate. Hypotension can be a limiting factor, so you have to use it judiciously. And the adverse effects would be the same as we all know, would be hypertriglyceridemia, increased CO2 for lipid emulsification vehicle. Careful monitoring of triglycerides is essential, and propofol infusion syndrome is something which we need to be careful when you're running it for a longer period of time. Hypothermia, specific effects of hypothermia are still unclear. Further beneficial effects of therapeutic hypothermia demonstrated in lab-based studies have not translated in all brain injuries as dictated by beneficial effects on neurological outcomes. The Eurotherm trial, where they kept the temperature from 32 to 35, had to be terminated early. The treatment group had a lower Glasgow outcome scale. So early short-term prophylactic hypothermia is not recommended to improve patient outcomes in diffuse injury. Surgical arm is important. Surgical decompression via craniectomy or with or without brain amputation is an old therapy that is increasingly gaining resurgence as a rescue therapy from malignant cerebral edema. The surgical treatment is applicable in a variety of brain injury that have space-occupying components in the intracranial vault, including malignant ischemic strokes, traumatic brain injuries, ICH, encephalitis, and obviously tumor surgeries and all. Decompressive craniotomy, is it really worth it? Brain Trauma Foundation says it has a level 2A evidence. Bifrontal decompressive craniotomy is not recommended to improve outcome as measured by Glasgow Outcome Scale. Score at 6 months, post-injury in severe TBI with diffuse injury without mass lesions. With an ICP value of more than 20 for more than 15 minutes within 1 hour that is refractory to first tier medical therapy. So if we look at these trials of decompression, secondary decompression and primary decompression, early and neuroprotective therapy, the DECRA trial functional outcome was worse. If we look at the last year therapy as a last ditch effort, it did decrease mortality, but there were higher rates of vegetative state patients, so the burdens on the family actually increased. And then if you look at the primary decompression of rescue ASDH, which is a randomized evaluation of surgery with craniotomy for patients undergoing evaluation of acute subdural hematoma, the extended Glasgow Coma Scale was better in this subset of patients, and so it is obviously recommended for acute injuries and acute subdurals. What about decompressives in strokes? A lot of trials have come in, like the Destiny, Hamlet and the Decimal trial. If you compare it to the medical arm, the mortality does decrease. Post-stroke, if you need to do a decompressive, the mortality does decrease. And if you look at the modified Rankin score, more than 4. So that is more or less equivalent to the medical arm. So what about decompressive craniectomies for intracerebral hemorrhages? The American Heart Association guidelines on the management published in 2015 suggest a favorable outcome of decompressive craniotomy in ICH with midline shift and increased ICP as compared to the medical management alone. So if you want to have one chart, this is the chart which would give you all the modalities of cerebral edema and how to treat it. It would have both the medical arm and the surgical arm and how to go about it. And with this, I would like to end my presentation. Thank you for your patient listening.
Thank you, sir.